The Tinnitus Retraining Therapy, TRT, is around for over 30 years. And indeed, as you mentioned, I'm a neuroscientist who just happened to be involved in tinnitus and decreased sound tolerance, although my main interest was brain plasticity, auditory system, vestibular system, pain, etc. So how TRT started? Very frequent question which I have, where TRT came from. I got dragged, to put it bluntly, into the tinnitus field at the beginning of 80s by Professor Clarence Sasaki at Yale. I was on my sabbatical at Yale University in New Haven at this time. And at this time, the situation was quite difficult. There was no animal model of tinnitus, only clinical results were available. And model of tinnitus and approaches and research focus totally on the inner ear and at most auditory nerve. Results from literature were quite conflicting and it was difficult to find out what to believe in. So it started from the development of animal model of tinnitus in 83, which was published in 88. And during creating this model, I had to learn about tinnitus a lot, and I was reading everything which was possible and impossible. As a result of this thinking about tinnitus, I create something which is known as the neurophysiological model of tinnitus, and at the same time, basis of TRT. I presented this model to Dr. Jonathan Hazel and to Jackie Sheldrake in London in October 88. They liked the idea, start using this literally next Monday. Soon reported positive results, which was very encouraging to me because whatever I proposed at this time was totally contrary to whatever was considered to be true about tinnitus. The first paper, which described the neurophysiological model of tinnitus and basis of TRT, was published in 1990, so ages ago. And the first center which was using TRT was Dr. Hazel in London in 1989. Then in 1990, I created center at the University of Maryland at Baltimore. Now we have over some centers which are using different version of TRT in over 30 countries. What was general idea of the model? What was new at this time? The main concept was that for 80% of the people with tinnitus who are just experiencing tinnitus but have no problem with this signal, tinnitus signal, it is neuronal activity within auditory pathways, which is perceived in auditory cortex as tinnitus, is restricted to auditory system. And this is, as you can imagine, goal of treating patients to revert them, to push them into the category of experiencing tinnitus and not having problem with it. When we start having tinnitus patients, what model postulate that this is happening when this tinnitus-related neural activity starts spreading to other structures in the brain, mainly, although not exclusively, to emotional system, so-called limbic system, and to autonomic nervous system. And then people with tinnitus became patients who are suffering because of the tinnitus. And this was a revolution at this time because I proposed going not only outside of cochlea, not only outside of auditory nerve, but totally outside of a auditory system. Auditory system in this model is secondary. It's needed because we are hearing tinnitus, but it's secondary. Now, this tinnitus signal can travel to this different part of the brains through two pathways. One is pathway which involves our thinking, perception, evaluation, cognitive part. And the other one, which is going through subconscious part, through some structure which is very well known in the auditory system, without going through our perception and evaluation. So we have like two loops. And this applies not only for tinnitus, but as well as I'll be talking about misophonia, when external sound is affecting auditory.
This is a short interruption from today's video to announce the Tinnitus Quiz. Are you frustrated by your tinnitus? Does it affect your ability to concentrate or fall asleep? If you're ready to find lasting relief from tinnitus, visit tinnitusquiz.com to get personalized solutions and treatment techniques to help you manage your symptoms today.
So, what is TRT? TRT is a method aimed at habituation of negative reactions evoked by tinnitus and/or due to a decreased sound tolerance, hyperacusis, and misophonia. In case of a tinnitus, patient still perceive tinnitus, but patient is not bothered by it most of the time and can live a normal life. In the optimal situation, is not bothered at all. And what's interesting and important in this as well, but once habituation of reaction is achieved, then habituation of perception, that means hearing tinnitus smaller and smaller proportion of the time, is achieved automatically because the brain automatically habituates all unimportant stimuli. There is no need for doing anything extra. And TRT, if we go to the specific mechanisms, which I'll be not talking that much today, is focused on extinction, that means removal of subconscious conditioned reflexes connecting auditory system, the limbic and autonomic nervous system. And again, as I mentioned, we have two loops, subconscious and conscious, and this dominant, subconscious loop is dominant and is governed by, controlled by principle of conditioned reflex. Now, next thing, which is different from majority of other methods, since treatment is aimed to work above all the site of tinnitus source, therefore, etiology of tinnitus is irrelevant. We are not trying to do anything with tinnitus signal and tinnitus source. In practical term implementation, TRT consists of counseling, teaching, very intensive, and some therapy, which are both based on the neurophysiological model of tinnitus. Now, how TRT is different from other methods? As I mentioned to you, we are trying to habituate tinnitus. What does it mean from the point of view of a mechanism? If you have a tinnitus, which is causing by the spreading this activity to other centers in the brain, is causing negative reaction. Now, medication and cochlear electrical stimulation, masking, majority of the sound therapies are trying to do something with tinnitus signal, remove it, abolish, to achieve this famous tinnitus cure. On the other side, psychological treatment and medication aimed at psychotropic medication at emotional system are trying to decrease or remove reactions induced by tinnitus. How TRT is different? TRT is not trying to do anything with a tinnitus signal. It's not trying to act directly on mechanisms responsible for reaction. It's trying to block spreading of this tinnitus signal to other parts of the brain so we do not have a reaction. So this is a fundamental difference between TRT and other methods. Now, treatment. Let's say a few words about tinnitus. But final goal of TRT is the tinnitus, hyperacusis, which roughly can be defined as a decreased tolerance to sound, which depends only on its acoustic characteristic, and misophonia, which is decreased sound tolerance only to specific sounds, cease to have an impact on patient life. And I believe this should be goal of any treatment, not only TRT, is primary for TRT. Now, what sometimes is creating confusion, I'm getting question, is tinnitus retraining therapy or is hyperacusis? Well, the TRT was created to be brief, but from the very beginning, hyperacusis has been part of the model, and TRT, even classification of a patient, include evaluation if patient have hyperacusis or not, treatment is different, and so on. And misophonia, since it was proposed in 2001, we introduced concept of misophonia and first treatment for misophonia in 2001. And again, tinnitus signal might remain unchanged, and normally is unchanged, but it will not induce negative reaction. But because of the way which emotional system is interacting with the auditory system, is going this direction as well, loudness, perceived loudness of tinnitus on average is dropping to about half of initial value in case of a treatment with TRT. For hyperacusis, the goal is to restore normal level of tolerance to external sounds. And for misophonia, the goal is that bothersome sound, called misophonic triggers, cease to evoke negative reaction. And what are two main components of a treatment? I mentioned already intensive counseling and sound therapy. Counseling teaching is aimed at explanation of mechanisms of treated disorder and physiological mechanisms used to achieve control of those disorders. So patients need to understand what's going on, and having this knowledge, use this knowledge for his or her benefits. Sound therapy, the main role, not the only one, but main role is aimed at decreasing the strength of neuronal activity perceived as a tinnitus evoked by external sounds, hyperacusis misophonia. And again, implementation of this is highly individual, and again, it depends on category of a patient, on individual case, and it's not just simple get exposure to sound, avoid silence, and everything will be fine. Although, as I will be showing in a moment, it helps too. So, results of TRT. First thing which I would like to stress, that I believe, as well as I think majority of the people involved in tinnitus, that we need validate questionnaire to assess the tinnitus severity. And from various over 20 questionnaires, tinnitus handicap inventory, THI, and tinnitus function index, TFI, are frequently used. I would like to stress that we need something which is aimed at tinnitus severity and not just improving general well-being, decreasing depression, and so on and so forth. You need something which addresses tinnitus specifically. Now, decrease of 20 points of THI score has been shown to be clinically significant. It's as well postulated that 13 points of TFI is significant as well. I would like to point out that these are very lax criteria. And actually, for my patient, majority of my patients, they are getting better with 20 points improvement, but at least 20 points is something which you can consider minimal improvement on THI to expect that patient will not suffer that much or at all. Another point which unfortunately is frequently misinterpreted in literature. Clinically significant improvement on questionnaire need to be statistically significant, and normally is. But statistically significant improvement alone is not sufficient to claim clinically significant result. And there are methods like, for example, transcranial magnetic stimulation, which definitely are giving some improvement, but this improvement is so small, typically, that it does not have any practical implication for patient. But we have 400 or more people in the study. This small improvement, which is not significant clinically, became statistically improvement. So there are two things. And actually, in the meeting of TRI, Tinnitus Research Initiative in Nottingham, a special lecture, special session devoted only to this issue. Now it's over 160 publication medline for tinnitus retraining therapy, and vast majority of them are showing positive results. Now, the study of Jim Henry was actually first to publish randomized clinical trial on over 100 patients. Are very interested. It was published in 2006, and I'll be talking about this in a moment. And a number of centers have shown a TRT success rate of around or above 80%. So main result, which I would like to briefly present. Henry study, which is TRT versus masking. CIMA, it's an excellent center for cognitive behavioral therapy, considered to be one of the best, which was published in Lancet, again, excellent journal in 2012. And some of our results presenting different. So what was Henry? It was one group was TRT, it was real TRT. Jim Henry knew TRT and implement this correct. And another group, which he was calling tinnitus masking, calling it sound relief therapy, because patients were instructed to sound set at comfortable level, aiming at immediate perception of some relief, masking if possible. So it wasn't masking as Jack Vernon was teaching me. Counseling was minimal. So results which I'll be presenting you, which he got, basically is something which you can expect if you just tell patient, use more sound, use hearing aids, use sound generator, tabletop machine, whatever, 24/7, avoid silence, and that's it. And bye-bye. This result you can achieve if you are just using this, what Henry was calling masking. And here you have results. Tinnitus, THI score, months of a treatment, and what we are seeing. But indeed, but just plain use of a sound, doing nothing else, is causing that you have an initial improvement for half a year, and then you have a plateau. And all the improvement is about 10, 12 points. So it's below this famous 20, but it's something. And please notice, you're not doing much of anything, just telling patient use sound. In case of a TRT, situation was quite different. First of all, you have a progressive improvement, which is proportional to time of a treatment, which is supporting postulate that treatment was actually doing something, and the longer you're using treatment, better results. And you get a finally difference of about 30 points. Proportion of a patient who reports some improvement was getting after 18 months to close to 90% in case of a TRT. Now, what is another very interesting point is that if you divide tinnitus patient with moderate, big, and very big problem, and using different measures called effect size D, it should be above at least 0.5 to claim that this method is doing something. As you see in case of a masking, you have some improvement, partly when it's a big problem, not very big problem. For moderate problem, you are not seeing much of an effect. It's about 0.7, 0.8, which is great. Well, it's not great, but something. It's definitely doing something. In case of a TRT, first of all, again, you can see this linear dependence on the time. Even for moderate problem, you have about 1.3, so excellent results. And for very big problem, for catastrophic tinnitus, you have this D above 2, which is incredible, powerful, and not really heard about. Now, if we look deeper into the comparing Henry results and CBT results, and again, we're lucky because the CIMA and Henry were using THI, both of the groups, so we can compare head to head, apple to apples. So Henry, with just use the sound, don't cancel, don't do anything. You have a 12 points improvement. Again, this is 20 points. So on average is 12, to some people who are above 20, some below 20, but is something, right? And what is interesting, that this group here, this green square, are result of CBT done by the best specialists in the world according to all the rules and regulations. And as you see, results of CBT are basically identical to results of Henry, who just said use the sound and don't bother with anything else. Actually, the fact that in this group CBT, we have a control group who are using different type of counseling, some counseling, but different one, results are worse than just using sound. So inappropriate counseling can actually make situation worse. On average, they have only 5 points. In the case of a TRT, as you see, Henry's result improvement is close to 30%, and we are having the same 30 points of improvement in our data, but just we have a little bit faster, and as you see, we have a significant clear, it's not significant statistically or clinically, but clear improvement after 1 month, and from 3 months on, you have a clinical and statistically significant improvement. So it was a lot of changes in TRT implementation over 30 years. Misophonia was a huge change, a recognition of importance of condition reflexes and subconscious pathways, and this resulted, plus other things, extensive modification of implementation of counseling. Counseling is very different than whatever we're using 30 years ago, although all the main principles are the same, but implementation and stress at different components is different. Now, in case of a sound therapy, we have again number of changes. Precise measurement of a sound in the ear, canal using real ear measurement, which caused a revolution in how we are treating patients with hyperacusis or misophonia. We have a specific protocol for sound protocol for misophonia, and higher stress is put on hearing rehabilitation. Which kind of changes we're observing? The main change is simply that when I was starting in the 90s, it was necessary to wait about 1 year to see clear improvement. Now, as I was showing you data, It's on average is 1 month, with statistically significant improvement after 3 months. We have a higher effectiveness of treatment for decreased sound tolerance because previously cases with misophonia were basically not successful, and increased extent of help of hearing loss.